Hey everybody, welcome to another episode of the OIG Roundtable. Excited to talk about this week's topic with my two partners in crime, Wade McFall, or McFall if you're in the Northeast. Depends, I guess, where you are in the country. Where in the world is Waldo? Retired Assistant Special Agent in Charge from the Office of Investigations out of the LA Field Office, and now a manager on our SIU investigative team. And Matt Kachansky, retired executive from HHS OIG and the retired Northeast UPIP director, and now our director of our SIU team. Matt's on his fourth career. It's crazy for a guy that's only 30 years old. You've done so much. Yeah, it's really, as my father used to say, be nice to the people you meet on the way up because you're meeting them on the way down. Good to see you again, my friend, is what I say.
Anytime, boss, anytime.
And Jason is out. He's still out on vacation. He's sailing the 7 seas, so he's enjoying a long vacation that he's never had in his whole life. So good for him. So today I've got some notes because we really got a packed discussion here. Today we want to talk about investigations, but a little bit of a twist on investigations, and investigations that deal with ancillary services. So we're talking in ancillary services, we're talking about things like MRIs, CTs, radiology related diagnostic services. We're talking about lab services. We could even go as far as to talk about things like durable medical equipment, DME, whether it be wheelchairs or things of that sort. And there's a wide body of regulation on that. There's a lot of information that's out there in the public domain about it. The first thing I want to do is I want to share the screen, and I want to just kind of let everybody know that there is a document that's out there that CMS has put out through the Medicare Learning Network. If you're not familiar with the MLN, the Medicare Learning Network, you should know about the MLN. The MLN are the fact sheets that come out. And they provide a lot of guidance and a lot of information. So we're going to be talking a lot about that. Interestingly enough, I was at a meeting last night of a local AAPC chapter on a panel for their CEUs. And one of the discussions came up about LCDs and NCDs and how the auditors and the coders in the group were very vocal about the fact that when providers get into debates with them about documentation, the one thing I really enjoyed hearing was that by and large, what these coders and auditors are doing is they're pulling up NCDs and LCDs and giving it to the providers and saying, take a look at this. If your documentation isn't saying what's in this policy, this is why these denials are coming in. So kudos to the auditing and the documentation people out there, because they're looking at things like the Medicare Learning Network documents and working to educate the provider community. But I think we got to start off and Wade, I want to start with you because from an investigative perspective, the thing about ancillary services that is a little bit of the challenge is that typically when you make a request, whether it be a subpoena, whether it be part of payment integrity, making a request for documents, when you're looking at these ancillary services, let's take, lab services, whether it be a blood test, pathology, something like that, there's typically only a couple of documents that the lab has. It's the order from the referring provider and it's the test results. And, oftentimes, as a result of just those two documents, providers in that space are oftentimes seeing denials for a lack of medical necessity. Well, the issue is you've only got two pieces of paper, so how do you even make, that determination? And so you've got to start to have a little bit of sleuthing. Who is the referring provider? Are they in network or are they out of network? So let's talk a little about that. Like some of the challenges that you've seen and that you've been engaged in kind of circumventing or short-circuiting that lack of documentation. Because what you don't want, right, is you don't want an instance where you kind of wholesale deny a whole bunch of claims and then during an appeal, the provider in their appeal wins because there's other documents. In the initial request for documents, the provider, the supplier, the lab, whatever it may be attesting that they're providing all of their documents. And they're not lying. They're providing all of their documents. It results in denials, and then you go through these appeals. So, there's a whole bunch of investigative factors there, right?
Right. And it's really just one other step that you kind of have to go through in the investigation, whereas like you said, if they don't have the documentation, you have to go to the original provider, I guess is one way to put it. Because they are ancillary services, they're not like a standalone service. There shouldn't be a situation where there is just a lab procedure or claim. There has to be, some kind of doctor's visit to order the lab or to order the MRI or whatever. So it's not a standalone. There has to be another appointment basically to generate that type of claim. So now instead of just going to the lab for the records, if you're doing the auditor, the CPC has to go through back to the original claim or the original doctor's visit in order to get that, if we're looking at medical necessity or whatever. So it's just another step. You have to go beyond requesting it from the lab or the DME company or whatever, go to that original appointment basically.
Right. So one of the challenges, and Matt, I want to go to you, on this is, one of the challenges, and we've discussed this before in prior podcasts, is the fact that under CMS rules, providers have 12 months to submit their claim. And so the problem that inherently exists in ancillary services, whether it be genetic testing, we see that a lot with genetic testing in the lab space, the COVID testing in DME, is the fact that you have a provider who may be quick to submit a claim, but you may have the referring or the ordering provider that may not be quick to submit their claim to establish that doctor-patient relationship. And so, the challenge is going to be, is this a provider that's in the network for the commercial payers? Is it out of network? How does that relationship work? And sort of the challenges from the analytics perspective on getting that fulsome amount of data that you would need to do a complete investigation.
Yeah, we worked with CMS a lot on the no prior relationship models for data, where, especially with DME, we would see equipment being delivered to a beneficiary ordered by Dr. Smith. We checked Dr. Smith's history with the patient who got the equipment. There's no such relationship there. And many times it was because it was a telemedicine, telefraud type of situation. But in other times it was because Dr. Smith hadn't submitted their claim yet. So we were trying to work with CMS to say, can't we put a payment edit in place where you deny the claims if there's no prior relationship with the ordering physician? And they would say no, because of the 12-month rule of the doctor not having to submit their claims for 12 months. They're just overlapping. So you've got to take that into consideration when you're doing your data analysis. The first thing you should look for is the ordering physician to try to get the records, as Wade brought up. Sometimes it might not be there because either they haven't, the records might not be there, or the claim from the provider might not be there because they haven't submitted yet. So you're going to have to delay your investigative steps or contact the provider without them having even submitted a claim, hoping that they'll respond. Because if there's no claim, they have no responsibility to respond to us.
Right.
Hopefully that they're participating in the program, because then again, no response, no actual authority for us to go and get those records. So it's very difficult. One clarification I want to bring to something Wade talked about, that MLN, one of the requirements for a laboratory under CMS rules is that they either have to have on site the documentation from the provider, from the ordering provider, the medical records that substantiate the need for the test, or get them if requested by an investigating agency, such as the UPIC or a plan. So I don't know if it's fair or not, but it's up to the laboratory to go and get the documentation for them to substantiate the medical necessity of the tests that they conducted and submitted for payment.
Right. So I have up on the screen from that MLN document, it shows here, if you bill laboratory services to Medicare, you, meaning the lab, must get the treating physician's signed order or progress note to support the intent of the order, and documentation to support the medical necessity for ordered services. So the challenge there is that the first part is going to be in the lab's possession. they're going to have, we hope, they're going to have that requisition for that test. It could be a blood test, pathology, COVID, whatever it might be. You've got that signed order, right? And, there's a whole thing about whether or not the order isn't signed or not, whether there's standing orders. We'll talk about that in a second, but that's the first part. But the key indicator on this one is, and documentation to support medical necessity for ordered services. And the important piece of this is that CMS is readily acknowledging and notifying that these records may be housed at another location, referring physician's office, for example. And the important piece of that is that it is incumbent upon the lab to get that information. So, in a world where you've got a provider, so let's not talk about Medicare for a minute, because you've got participating, non-participating, and opt-out physicians. And so there may not even be a relationship, but if you're an opt-out physician, you can't even make the referral because you're not part of the program. But what if you're a commercial payer where the lab is in network, your doctor's out of network, and you don't have that relationship with the doctor, right? It's incumbent upon the lab to get that documentation. And particularly with Medicare, it's not the program's responsibility to go hunting and pecking for the medical documentation. It's the lab's responsibility. Now, we've all done lab investigations and probably can say with pretty high level of certainty that in most instances, the labs do not get the accompanying medical records. They get the requisitions, they get the sample, and they get the test results, right, that go back out. There's, just a couple of things. And so the question then becomes, in that world, the delay that then from an investigative perspective, because Wade, I want to go back to you, is right on a typical request that comes out, right? You've got your 30, 60 days to turn over those documents, whatever. And, this kind of gets back to this whole premise of why do healthcare fraud investigations sometimes take a long time? And the premise that I will stand by until I am no longer able to do this job anymore is going to be that most of the time, the lag in being able to quickly conduct an investigation is out of the investigator's hands. It's waiting for documents to come in. And this is a great example, right? Like it's the waiting game. But while you're waiting for those records, you could be doing 100 other things, right?
Yeah. And as Matt said too, you got to kind of look at it like, is it even fair that the lab has to go back and, it's resources being spent on something other than, generating income for them. So you're going to have to call them and require that they do this extra work to go back to the provider to get these records. So you're going to have to be kind of lenient with, giving extensions, and, you can't stick to, well, it's 30 days is 30 days. If they have to go to this other provider and go kind of out of their normal scope of work to get these records for you, you're going to have to give them, a reasonable amount of time, whether it's 60 days, 90 days, whatever. But it is going to delay the investigation, like you say. You're just going to have to do other things in the meantime, and that's just going to be put on the back burner while you wait for those records. There's nothing else you can do about it.
And I think part of the challenge is that when this occurs, the question really from an investigative perspective, and it's an individual decision that investigators have to make, is who do you go to get those records? Do you go to the lab and have them go to the provider to get those records, or do you go to the provider directly? Now, my thought is if I can go to the provider directly, the ordering provider directly, I cut the middleman out, right? You save yourself a huge amount of time to go to that provider who ordered that test. One of the things that I would hope is that there's going to be a record, number one, but number two, is there going to be a claim from that provider, right? Because depending upon the time period, did the provider even submit that claim or not submit that claim? But if I can get those records without having to go back to the lab, I would want to do that just because I'm saving myself a step, right? I'm going to the lab, I'm asking them to get the records. They're not going to have them. They have to go to the provider or the ordering provider, ask for those records. The doc then sends them to the lab, and then the lab then sends them to us. So that creates another layer of time. We can put this into the sense of even like in the pharmacy world, right? When the PBMs are doing audits, right? The relationship between the PBM and the pharmacy exists. It doesn't exist between the PBM and the wholesaler. So the PBM has to request invoices from the wholesaler through the pharmacy, and there's that always that inherent delay in that turnaround of time. But Matt, so I want to go to you from kind of a practical perspective. Does it almost make sense if I'm the medical director or the chief compliance officer of a lab or something like that? Does it make sense to engage in my referring provider group that when they send an order, they send those medical records? Now that is, I think you're predicting that you're going to have an audit at some time, but are you creating this inherent burden because you're still required? And at the end of the day, the issue is going to be that you likely could get a denial for medical necessity on a test. But the reality is that the argument, if I'm the lab, the argument I make is, I'm not the one making the determination of medical necessity. I have a signed order from a physician. The physician or whoever it is, they have plenary licensure, so they can order things as they want. And is it really incumbent upon the lab, or is this a burden on the lab?
I think it is a burden on the lab, but there's two things I want to bring up. One is the labs usually have contracts with the providers or provider groups that are sending them the tests. As part of that contract, they should have in there either submit with or have ready in case of need the medical records to support the medical necessity of the test that you're submitting to me, so that we can get them in time and get them to the investigation. The other part of it is, labs should have the responsibility to some degree of having a compliance arm looking at the data and the patterns of the referrals they're receiving from providers to see if maybe there is a question of medical necessity. Maybe they're getting an overabundance of drug tests, urine drug tests from a particular provider group. Maybe they should then, their compliance group take a look at that data the same way that an investigative agency is looking at that same data, saying, boy, this doesn't look right. Let me go back and get those documents from the provider to make sure in a proactive way that there's medical necessity for these tests. And if not, then, set up something else with that provider about you've got to change your patterns or, whatever. So there's a responsibility on their part. It is a burden, but I think it can forestall any type of investigation that would come their way if they're more proactive.
Right. Well, and I mean, you take it to the next step, which is even if we're talking in the DME space, things like wheelchairs, power, whatever, you have it. You have plenty of instances. I've seen many cases where the ordering physician is ordering a power wheelchair of a certain type. And when it gets to the supplier is required to take an independent assessment, right? The supplier's got to go on site, do things like take measurements of doors, right? Because power wheelchairs are meant to be used for things like assisting with activities of daily living, ADL, right? So, my favorite cases were the ones where you would show up at the person's house to do an interview, the beneficiary's house, and the power wheelchair was outside on the porch. And the reason it was outside on the porch was it couldn't fit through the door, right? Like, hey, what's going on here? And in that instance, right, it's the DME supplier's responsibility, notwithstanding what the ordering physician is doing. Because in some sense, the ordering physician says, my patient needs a wheelchair for activities of daily living. The physician doesn't necessarily know that a power wheelchair is 36 inches, but the door weighs 20 inches, right? Like, these are things where an independent assessment needs to be taken. So it is a little bit of a challenge. So, as we kind of wrap up, Matt, I just want to address the last piece of this, which is this whole premise of standing orders. And there's a whole bunch of stuff involving standing orders, and the fact that standing orders are frowned on by CMS with some caveats, right? The one example that we talked about before we did this recording was, the diabetic patient in the nursing home who needs to get their glucose checked every 6 or 8 weeks via blood draw or something like that, versus some routine cadence of some standing order for something that's not directly medically necessary, like, in today's world, a routine cadence of COVID testing when we're not in the PHE, or quarterly cholesterol checks or something, and, a standing order that's targeted versus kind of a generic one. And you see that in primarily facility situations, right?
Correct. Yeah, there's two types of standing orders. One is patient specific and the other is population general. Patient specific is like you talked about, the specific patient that needs the weekly or monthly testing based on the condition that they have. And that's got to be documented, that the need for those standing orders. The other is, the perfect example is the urine drug testing orders that are done in a sober homes, where they want a daily drug test because that was their internal program. Everybody in the place got a daily drug test, which was then billed to whatever plan was the patient belonged to. That's a standing order that is not acceptable to most plans, especially Medicare and Medicaid. They've got to have orders that are specific to the patient based on the diagnosis or condition of the patient at the time.
Yeah, you bring up a good point, and I know we're running out of time, but you bring up a good point on those sober home, the UDT, the urine drug testing, and the whole point of that is that it's supposed to be at some point random, but if you're doing it Monday, Wednesday, and Friday, and you do that after a couple of weeks or whatever it is, you've kind of given away the farm, because if I know I'm getting tested Monday, Wednesday, and Friday, that means on Sunday, Tuesday, and Thursday, I'm having someone else do a pee for me into my fake bladder, into my fake bladder, so that I could pass my urine drug test. Not saying that I ever did that. I was an OIG agent for a long time, and we had random drug testing, so that couldn't be the case.
Tested for steroids, though.
It is something. Well, I am the first steroid failure, apparently. It's a slippery slope, and we're seeing in a lot of the cases that are out there now, with these ancillary services, that one of the big issues is that there is no documentation to support the medical necessity, particularly in these telefraud cases, for things like the genetic testing, those COVID add-on tests that were being done, the flu and strep and, the other suite of things. You're starting to see those cases come to fruition, where it's not just that there's a lack of a doctor-patient or referring provider-patient relationship, but there's just no documentation out there. And so the problem is that these labs, and if they're not, let's say we're talking about a lab that's not in cahoots, a non-fraudulent lab, which are just getting their samples, whatever it may be, where there's a separate issue that's going on that maybe they're not part and parcel to. I think that's probably a minority, because typically there's a organized crime element to these things, right? It's as I like to, the fraud triangle: the patient, the prescriber, and the supplier in those instances. But yeah, that becomes the challenge. Is there documentation to support this test? For labs that are out there doing this work, they're not collecting the patient records. And so it really does become this balancing act of getting those records and the lag time in getting those records and all of that. And that, I think, that adds a layer of complexity that is oftentimes missed by the outside on things like time-related issues. Why is it taking so long to resolve this case? But then also, at the end of the day, you have to feel for a lab that has an overpayment assessment of $1 million or whatever that dollar amount is, when, their argument is, we're doing, this is our subjective understanding. We're processing this. Now, the counter argument is there's clearly a policy in place that says you're required to do this, but there's obviously that balancing act. Every time a person goes and needs some sort of ancillary service or test, is the MRI facility, when they give you when the doctor gives you your order for an MRI, is the doctor also giving you a copy of your medical record to give, that doesn't happen. So there is that administrative burden.
At the UPIC, we had a case on a lab, and we did an on-site there. The lab seemed, legitimate, well above board, clean, had state-of-the-art equipment, had a compliance team in place, but they didn't have the medical records. We asked them to get the medical records from the ordering providers. They refused. They refused them. They just never got them. Right. So, we dinged the lab for hundreds of thousands of dollars.
But that's a different scenario. Like, you go to them and you say to the lab, hey, in order for us to determine medical necessity for this item service procedure, you've got to get the records, you know. Here it is in black and white.
Yeah.
And if they're not willing to comply, I mean, it's a regulation. You are, you know,
No,
that's
the lab didn't refuse it. They made a good faith effort to get them. It was the
right.
prescribing
Yeah, but I'm saying
physicians
at the
who
end of the
said,
day,
"Pound sand."
yeah, but at the end of the day, you still got, you know, conversely, the lab is getting dinged. Here's the rule. You've got to
Yeah.
get it. If the provider doesn't want to give them, then maybe you should be dealing with doctors that are not giving you pushback, right? Because
Yeah.
if a provider is giving pushback to one of its referring ancillary groups for medical care, maybe you have to have a
You know,
conversation with your
There's a
with your
question there.
provider, right? Yeah, this is a complex issue. I've had a number of discussions with some of our SIU clients on this because it's actually come up on a project that I'm helping work on right now, where we're working on a pathology project, and we've got hundreds of requisitions and test results, and now we're needing to go and collect up those medical records to establish that necessity. So it's part of creating, it's part of being objective and part of having a fulsome record to be able to have an objective, because otherwise we're making a subjective assessment based upon a minimal amount of information. And we want to be able to have, remember, audits and investigations are really 360 degrees. We have to have all of that. So yeah, it's a continuum. So we can certainly look back and revisit this. And I think we're going to start to see a lot more, particularly in the COVID space. I think we're going to continue to see a lot of these, particularly with these COVID add-on services. So it's a lot to talk about. As always, I appreciate your time. Thanks again, everybody, for tuning in to this week's episode of OIG Roundtable. Again, check out our website. We just did a refresh of the website. Us OIG guys, we have our own little link for some stuff. You can get our previous podcast. You can get our previous LinkedIn Lives, all from the website, Spotify, YouTube. Looking forward to June's LinkedIn Live. I'll be doing a conversation with a great lawyer that I've worked with for many years, Stephen Bittinger, with a firm called Kale Gates. He's down in South Carolina. He is an expert on challenging statistical sampling, and has had some really good successes and has some cases that are working their way through the courts, including circuit courts. And he's become one of the leaders in that. So I'm super excited to do that with him in June. And as always, you can get all of our newsletters and all of that by just signing up. Go to our webpage and sign up for the newsletter. You can also send us an email at hello@advizehealth.com. And until next time, we'll see you on the next OIG Roundtable. Have a good one, everyone.